Respiratory depression. Any more answers? Thank you, Susan, for that. Ask that.
Drowsiness.
Drowsiness. So the immediate side effect of morphine is nausea and vomiting. So when we start with intravenous morphine titration, first we give the patient injection metoclopramide 10 milligram. So that would be the first procedure. And as I mentioned, intravenous morphine titration, what is the procedure? Suppose you have an ampule of morphine with you. One ampule of morphine contains 1 ml, which is 15 milligram of morphine. So this 1 ml is diluted with 9 ml of normal saline, such that each ml of morphine diluent contains 1.5 milligram of morphine. And 1 ml is repeated every 10 minutes. This is the morphine titration process. I repeat, 1 ampule of morphine contains 15 milligram of morphine, and this 1 ml is diluted with 9 ml of NS, such that 1 ml of the diluent solution contains 1.5 milligram of morphine. And this morphine, 1 ml, that is 1.5 milligram, is repeated every 15 minutes. So before starting the titration process, we need to check the vitals of the patient, record the pain score and the drowsiness. And every 10 minutes, in every 10 minutes interval, we reassess the vitals, the pain score and the drowsiness score and repeat the dose. The endpoint of titration would be either the patient becomes drowsy or the patient has satisfactory pain relief. Whichever happens first would be the endpoint of the titration. So 1.5 milligram. So start with injection metoclopramide to avoid emesis or nausea. We start with injection metoclopramide, then check the vitals of the patient, including the respiratory rate and the pain score needs to be documented. And 1 ml of morphine. So 1 ampule contains 15 milligram of morphine that should be diluted with 9 ml of NS, such that each ml of diluent contains 1.5 milligram of morphine. And this 1 ml is repeated in every 10 minutes interval. The endpoint of titration would be either the patient feels sleepy or drowsy or patient has satisfactory pain relief, whichever happens first. So to make it more clear, suppose a patient comes to you for morphine and we decide, depending upon the pain score, the severity of the pain, the patient has presented with, as in this patient scenario, the patient has presented with severe pain, 10 on 10 pain, and we are planning for morphine titration. We started with the injection metoclopramide 10 milligram, and after that, check the vitals of the patient and record the pain score. So the patient, 10 o'clock, we started with the titration. When the pain score was 10 on 10, the patient was not drowsy. 1.5 milligram of injection morphine was given to the patient. 10 minutes later, the pain score was reassessed. The vitals were documented. The pain score became 7 by 10. The patient is still not drowsy. Then repeat 1 ml of diluent morphine, which is 1.5 milligram of morphine. Wait for another 10 minutes. Record the vitals again and record the pain score. The pain score in this patient has come down to 4. The patient is still not drowsy. So we are repeating 1.5 milligram of morphine again. Wait for another 10 minutes. By 10:30, the pain score, when recorded again, it became 1 by 10. Now, the patient has satisfactory pain relief. We are stopping the titration process here. So, 1.5 milligram of injection IV morphine was given in every 10 minutes interval, such that the patient with 3 doses of morphine, that is 4.5 milligram of total IV morphine, the patient had adequate pain relief. So suppose this patient needs to be sent. Hope this is clear to you. The morphine titration process, is this clear to you?
Yes.
Okay. So okay. Thank you. Thank you for the responses. So the morphine titration is done. The patient is right now having adequate pain relief. But now we want to send the patient home. How do we send this patient home? So to convert the IV morphine to oral morphine, we go with 1:1 titration. So 4.5 milligram of IV morphine, with 4.5 milligram, the patient had adequate pain, satisfactory pain relief. So now to convert it to orally, it is 1:1 conversion ratio. So you can send the patient on 4.5 milligram of oral morphine, but the available morphine tablets are 10 milligram. So we'll go with 5 milligram of oral morphine. So to send this patient home, we start him on 5 milligram of oral morphine every 4 hourly. So as per the principles of analgesic use, you might have already heard or gone through that before. The patient should be prescribed by the clock, by the mouth, by the ladder, and individualized treatment. So what does that mean? Always prefer the oral route. As much as possible, try to give the patient medications orally. Only if it is not possible orally, try for alternate routes. So, and always go by the clock. What does that by the clock mean? Can someone help me out in that? What does that by the clock mean?
Breakthrough pain.
Yeah.
SOS.
So, yeah, thank you for, yeah. Thank you. Thank you for the responses. So by the clock means that suppose you start a medication, yes, give the medication as per the action, as per the frequency needed in the optimal dose. Unless you give the patient the medication in the optimal dose, it will not be effective. For example, if you are giving a patient acetaminophen or paracetamol, what is the duration of action?
8 hours.
Yes, 6 to 8 hours. So for that person, it should be for a patient on paracetamol with normal hepatic function, you need to give him either 6th hourly or 8th hourly. Then only it can produce the optimal effect. You cannot give the patient a BD dose and expect the patient to have adequate pain relief. So that is what is meant by the clock. So depending upon the duration of action of the medication, you need to adjust or add the frequency of the medications. So by orally as much as preferred, by the clock. What does by the ladder mean? Anybody? So we have already seen the WHO analgesic ladder. So depending upon the severity of the pain, we go for step 1, step 2 or step 3, right? So always go by the ladder. Unless there is some other reason, always try to go by the ladder. So suppose the pain is not controlled with step 1, you go for step 2. Or suppose the severity of the pain is even more, then we go for step 3 of the ladder. So that is what is meant by the ladder. And individualized treatment. Individualized treatment means the treatment would be specific for each patient depending upon their treatment plan. So that are the 4 principles of analgesic use. So for oral morphine, now the patient, coming back to our titration process, the patient was given 4.5 milligram of IV morphine. Now we want to send the patient home. So 1:1 conversion ratio. So we are converting the patient or we are sending the patient home on tab morphine 5 milligram and 4 hourly is the prescription. By the clock, morphine should be given every 4 hourly. So at the time the patient wakes up, then 4 hours after that 10 a.m., 2 p.m., 6 p.m. and bedtime. Bedtime we are giving double dose. Why do you want to give double dose at bedtime? Anybody here is already using morphine? You have morphine in your institution, oral morphine?
Yes, ma'am.
Yes. So, okay.
Yes, ma'am.
Okay, there are a few of you who are already using morphine, right? So you might be knowing.
Yes.
We usually prescribe morphine every 4 hourly. Why do you want to give at night? Why do we want to give double dose? Yeah. Yes. Yes.
Long time.
Yeah. So we don't want to wake up the patient in the middle of the night and give another dose, which would come around 2 a.m. So we don't want to disturb the sleep of the patient, and at the same time the patient should have adequate sleep, adequate pain relief also. So in order to maintain the constant level of the analgesic in the blood, we provide double dose at night so that the patient has adequate pain relief till 6 a.m. in the morning or till the time he gets up. So that is why we provide double dose at night. And the patient should also be given 5 milligram of SOS dose. In between, if the patient has pain, the patient can make use of that. So for this patient, we have started him on tab morphine 5 milligram 4 hourly and 10 milligram at night and 5 milligram, the same dose as SOS dose. In between, if the patient has pain, the patient can make use of the SOS dose. So this patient came to your unit where you had the morphine ampule or IV morphine was there with you. Suppose the patient comes to a setting where you have only oral morphine. How do we go about that? So, in patients who are new to opioid, we usually start with 5 milligram of oral morphine every 4 hourly and 10 milligram at night and 5 milligram as SOS dose. But suppose the patient is already on weak opioids like tramadol or tapentadol, we go with 7.5 to 10 milligram of oral morphine every 4 hourly. So for opioid naive patients who are new to opioid, we start with 5 milligram 4 hourly. And for patients who are already on step 2 opioids, you can go either 5 to 10 milligram, like 7.5, or you can go with 10 milligram 4 hourly of oral morphine. Moving on with our story. So the patient was started, Mr. X was started on 5 milligram of oral morphine, 6 every 4 hourly and SOS dose. He had adequate pain relief for 2 weeks. But since last 4 days, he was needing 3 SOS dose of morphine per day. What shall we do now? So, any responses? You can unmute and talk.
We have to increase the 5 milligram to 10 milligram for fourth hourly.
Okay. So why do you want to go to 10 milligram?
Because he don't have and his needs for 3 SOS doses of morphine. So we have to increase the doses of 10 milligram.
Thank you. Thank you, Sister Sumati, for that. Yes. As many of you have already put in the chat box also that the pain is not under control. The patient is not having satisfactory pain relief and he is taking rescue doses of morphine. That clearly indicates that the morphine dose has to be increased. So how do we increase the morphine dose? Suppose a patient is taking 3 or more doses of rescue doses, you can increase the dose by 30 to 50%. As Sister Sumati has already said, we can either increase the dose to 7.5 milligram or to 10 milligram fortnightly. So when 2 or more than 2 doses, rescue doses are being taken, the patient's dose needs to be increased from 30 to 50% every 24 hours. So it can, this 5 milligram fourth hourly, you can either increase it to 7.5 fourth hourly or 10 milligram 4 hourly. Okay. So how frequently would you give SOS dose of oral morphine? So I have been telling you, we can go with the SOS dose of morphine. There, 5 milligram SOS can be given. So how frequently can we make use of this SOS dose of morphine? Any comments? Anybody would unmute and talk? Would like to unmute and talk? Please respond. So Asia says that whenever the patient feels pain, yes, whenever after 4 hours, we have different responses coming in. So to understand this better, we need to understand more about morphine, its action, its metabolism. Yeah. So we'll talk more about that. So morphine is a naturally occurring opioid that is being extracted from the poppy plant called Papaver somniferum. So from the seed of the poppy plant, Papaver somniferum, morphine is being extracted. And in India, it is legally permitted. The states which have legal permission to cultivate morphine are Madhya Pradesh, Uttar Pradesh, and Rajasthan. So these are places where morphine can be legally cultivated. And regarding the pharmacokinetics of morphine, absorption of morphine is a weak base. And when taken orally, it is absorbed from the small upper part of the small intestine. And morphine is hydrophilic in nature. And being hydrophilic in nature, its onset of action is slow and it has longer duration of action. And when given sublingually, the absorption is very low. And research even shows that the buccal and gingival absorption is also very variable. And morphine has a bitter taste. So now moving on to the metabolism. So when morphine is taken orally, morphine reaches the gastrointestinal tract and absorbed into the blood vessels. It undergoes first pass hepatic metabolism. So it gets absorbed into the blood vessels and through the portal vein circulation, it reaches the liver. And in the liver, morphine gets metabolized. So once morphine is swallowed, it reaches the gastrointestinal tract and it is absorbed into the blood vessels and through the portal vein circulation, it reaches the liver. So mainly morphine is metabolized in the liver, but minor part undergoes metabolism in the gastrointestinal tract as well as in the kidney. 90% of the morphine is converted to its metabolites. And morphine is converted to morphine 3-glucuronide and morphine 6-glucuronide. And this morphine 6-glucuronide is mainly responsible for the analgesic effect of morphine. So in the liver, morphine undergoes metabolism, glucuronidation, and it gets converted to morphine 6-glucuronide and morphine 3-glucuronide. The 6-glucuronide is a component that provides active pain relief. And 3-glucuronide is mostly responsible for the neurotoxic effects of morphine. So this process of orally swallowing morphine, reaching from getting absorbed and reaching the liver and undergoing metabolism, it takes around 45 to 60 minutes. And this metabolites to get into the systemic circulation and produce its effect. So it takes about 45 minutes to 60 minutes. And so when an SOS dose of morphine is given orally, it takes around 1 hour, 45 minutes to 60 minutes to produce its peak analgesic effect. So that is because the morphine gets metabolized in the liver mainly in the liver, though GIT and kidney are also other parts of the body where morphine gets metabolized, but majority of the morphine metabolism takes place in the liver, and morphine gets converted to its metabolites through glucuronidation, morphine 6 glucuronide and morphine 3 glucuronide. Morphine 6 glucuronide is responsible for the analgesic effect. So this process and this metabolites are released into the systemic circulation and they produce the analgesic effect. So it takes around 45 minutes to 60 minutes for morphine to produce its peak analgesic effect. So there should be a gap of at least 1 hour between the two doses of morphine. To make it more clear, suppose a patient was given morphine at 6 a.m. and the patient has no adequate pain relief at 7 a.m. Also, the patient reports that the patient has no adequate relief. That means that you have given enough time for the morphine to produce its peak analgesic effect. If still the patient reports that the patient is not having adequate pain relief, you can ask the patient to take one SOS dose of morphine. And you should wait for another 1 hour to see if the medication is effective or the pain is responding to the opioid. And then only another SOS dose can be given. So, in between two doses, if the patient has breakthrough pain means that sudden exaggerated pain coming in between, you can give the patient an SOS dose of morphine. The same dose of morphine is given as SOS dose of morphine and wait for 1 hour to see if the pain is responding. And then only another SOS dose should be given or another dose of morphine should be given. So there should be a gap of 1 hour between the SOS doses or between any dosing of morphine when given orally. Hope it's clear. So next, we are moving on with the patient story. So this patient, we had started him with 10 milligram of oral morphine 4 hourly with was having stable pain relief. So we have increased the dose to 10 milligram 4 hourly, but the patient finds it very difficult to take every 4 hourly. He understands that it is important to take the medications and is willing to take it, but he is requesting if you can give it less frequently. Is there any other ways by which we can address this need of the patient? Suppose such a patient comes to you and asking, I understand that this is important and I would like to adhere, but I find it difficult to take the medications every 4 hourly. What are the other options? Is there any other option?
Ma'am, 6 hourly.
6
Advice
hourly. Sir. So, yes. So, we have sustained release preparations of morphine available. So, we cannot go for 6 hourly preparations because usually the duration of action of morphine is 4 hours. Unless there is some other associated issues. Otherwise, the duration of action is every 4 hours. So what we can do is we can go in for sustained release preparations. So sustained release morphine, it is 12-hour action. The duration of action is 12 hours. So we can convert this patient whom we are seeing. The patient was on 10 milligram of oral morphine every 4 hourly. That means that the patient is on 60 milligram of oral morphine in 24 hours. So that patient can be converted to sustained release preparation. So 30 milligram twice daily. We can give the patient 30 milligram of sustained release morphine twice daily. So what are the other preparations of morphine available? Morphine is available as aqueous solutions. It is available in tablet form where we have immediate release preparations as well as sustained release preparations. And as we already saw in intravenous morphine titration, we have injectable forms of morphine also. So these are the various preparations of morphine available. Moving on to the next story. So the next stage, the patient is on 10 milligram of oral morphine 4 hourly for the past 6 months. Now, he was brought to you with excessive drowsiness, and on examination, we found that his serum creatinine level is 5 milligram per deciliter. Should we do anything with the morphine dosage? So the patient is on 10 milligram of oral morphine 4 hourly, but has reported or brought to us with excessive drowsiness, and his serum creatinine was found to be 5 milligram per deciliter. Should we do anything with the morphine dose?
No need to increase, ma'am. So already she's getting increase of serum creatinine.
Yeah.
So no need to increase the mine.
Yeah. So we don't want to increase the dose of morphine. But do we want to do something else? Priyanka says that we have to reduce the dose. Why? Do you agree? Does anybody else agree with that?
Please respond. If you are not responding, how our session will get in an interactive one?
Yeah, okay. So Sarla says that you should reduce the dose. We should reduce the dose. Why do you think that we should reduce the dose?
Patient with excessive drowsiness plus increased serum creatinine also. So that is the reason.
Yeah. So why could the patient be so drowsy when there is increased serum creatinine?
That kidney function it will.
Yes. Yes. Thank you. Thank you, Sister Sumati, for that. Yeah. So to understand this better, we need to know the excretion of morphine. And yes, morphine is excreted by the kidney by glomerular filtration. So what happens? We saw that the patient's serum creatinine is 5 milligram. So in patients with renal failure, what happens is that the morphine metabolite, the morphine 6 glucuronide, gets accumulated and its clearance is decreased. So, and the half-life is prolonged. So what happens? The morphine 6 glucuronide is more available in the blood and its clearance gets decreased. So there are chances of developing toxicities. So either you have to increase the spacing between the medications, like make the dosing 3 times daily, or reduce the dose as such, or go for alternate opioids. So as the excretion of morphine is by glomerular filtration, if in case of renal failure, what happens is that the metabolites gets accumulated and is clearance is delayed. So we need to either reduce the dose of morphine or increase the spacing between the doses. So you can, the patient was on 4 hourly dose, you can either go for 3 hourly, 3 times a day dosage, or you have to reduce the dose of the medications as such, and otherwise we'll have to go for renally safe other opioids. Hope that is clear. So now the patient was sent home, and right now we have reduced the dose as well as we have increased the spacing between. The frequency is also reduced. So we have made the morphine 5 milligram 8 hourly and sent him home. But after 2 months, what happened? The patient was deteriorating and is reaching his terminal stage. And at this point of time, he was unable to swallow anything, including morphine. What do we do for pain relief at this stage? So the patient has pain, but he is unable to swallow anything. What can we do? And the patient is at home.
We have to give injection morphine now.
Injection morphine. Yes.
With diluted 1 ml 15 milligram plus 9 ml of saline to dilute and give the injections.
Yes. Injection morphine can be provided, but in home settings, is this always practical to send the patient on intravenous morphine at home? So it could be difficult, right? The family might not be able to handle it well at home. Though we send morphine at home, we try to convert it to subcutaneous route at home. But still, are there any other measures by which we can send the patient home? The patient wants to be at home in his terminal stage. So now to understand this, what are the routes of administering morphine? So morphine can be administered orally, intravenous or through subcutaneous route, rectally, epidurally, and through the intrathecal route. So these are the various routes of administering morphine. We don't have.
We have to teach the subcutaneous method to give the morphine.
Subcutaneous method, that is one option. Is there any other option for sending this patient home who's on 5 milligram of oral morphine 8 hourly? Anyone? So the same patient scenario.
He cannot.
Sorry?
He cannot take in oral, ma'am. So how to give? Swallow?
We cannot.
Unable to swallow, ma'am. So we cannot give 5 milligram orally.
Yes. So what is the other option left is that we can send the patient on rectal morphine. The same 5 milligram oral morphine can be used rectally for that patient. So the absorption rate is almost comparable with that of the oral preparation when given rectally. So this 5 milligram tablet, just 1 drop of water and you can apply it on the rectal mucosa. And as I mentioned, the absorption is almost comparable with that of the oral route. So that would be another option. Yes, you can go for subcutaneous injections also, but what we practice in our home settings and what would be the easiest way for the patient and the family would be the rectal preparation of morphine. So the same oral tablet can be used rectally. Okay. So now moving on to another patient story. So this is another patient she is 55 years old with carcinoma of colon and has abdominal pain, which is a continuous. And she is on 10 milligram of oral morphine every 4 hourly. And right now she is not needing any SOS dose of morphine and she is having satisfactory pain relief. So the doctor has asked them to replace morphine with 25 microgram of fentanyl patch. So the next day, the patient report to you telling that after the patch has been replaced, even after 5 hours, the patient is not having any pain relief. So they replace the fentanyl patch. What will you do now? So the patient was having adequate pain relief with oral morphine, 10 milligram 4 hourly. So no need of rescue doses. So the doctor asked him to replace this oral morphine with 25 microgram of fentanyl patch, and the patient did so. But even after 5 hours, the patient was not having any satisfactory pain relief. So the patient replaced the patch. So to understand this better or more, we'll learn about fentanyl. So what are the fentanyl is a synthetic opioid. It's a synthetic step 3 opioid, which is more potent, 100 to 150 times more potent than morphine. And this, it is the available preparations of fentanyl are, fentanyl is available in injectable form, it is available as transdermal patch, it is also available as oral transmucosal fentanyl citrate. So that is, it is available in the form of lollipops, lozenges, etc. Fentanyl is lipophilic in nature. It is faster acting, and it has short duration of action. And 60 milligram of oral morphine in a day is equivalent to 25 microgram per hour of fentanyl patch. Suppose a patient is on 60 milligram of oral morphine in 24 hours, that patient can be replaced with 25 microgram of fentanyl patch. So when I say 25 microgram of fentanyl patch, that means that 25 microgram of fentanyl is being released every hour. It's 25 microgram per hour. So let's learn a bit more about the transdermal fentanyl patch. So the transdermal fentanyl patch, it is usually applied in intact skin with no hairs, but ensure that there are no aberrations in the skin. And this is because it affects it influences the absorption of fentanyl, and also the temperature change can also influence the absorption of fentanyl. And this patch, it forms, when it is placed on the skin, it forms a subcutaneous depot of the drug, and then this is slowly released into the blood. It takes around 8 to 12 hours for the drug to produce effective analgesia, and it lasts for 3 days, 72 hours. That is, when a patch is kept, it will keep the patch for 3 days, and fentanyl patch is removed once in 3 days. And it is not suitable for patients with unstable pain. So suppose a patient is having breakthrough pains, fentanyl patch might not be helpful in that situation. This is because once you apply the patch, you have no control over the rate of drug being dispensed into the blood. So we assume that 25 microgram, suppose it's a 25 microgram patch, 25 microgram of fentanyl is released into the blood per hour is what we assume. So suppose this is placed and the patient is having breakthrough pain, we don't have much control on the drug. We don't know how much is left in the drug or how much is being released. So it is not stable, not suitable for patients with unstable pain. So in our patient whom we saw right now, the patient was having adequate pain relief. I mean, satisfactory pain relief. Go back to that patient story. The patient was having adequate pain relief and no need of SOS dose of morphine. And the patient was on 10 milligram of oral morphine every 4 hourly. That means that 60 milligram, 10 milligram of oral morphine means 10 milligram 6 times in a day. So that is 60 milligram of oral morphine in 24 hours. So that patient can very well be replaced with 25 microgram of fentanyl patch. But what went wrong here? Can someone tell me what went wrong here? So the fentanyl patch to produce effective analgesia, we have already seen that it takes around 8 to 12 hours. But within 5 hours itself, the patient has replaced the fentanyl patch, saying that it is not effective. So it takes around 8 to 12 hours for the patch to produce its analgesic effect. Okay. So now, just to previously, we have a patient, just a 70-year-old man with carcinoma of lung who has a thrombing pain on the right front of the chest, which is continuous in nature with a severity of 5/10. He is a non-epileptic and he is on levetiracetam 500 milligram twice daily. What would be the right choice of opioid for this patient?
Please respond.
You can either unmute yourself and talk, or you can type in your chat box. So what would be the best opioid for this patient? The patient has a continuous pain, throbbing kind of pain, which is with a severity of 5/10. The patient is a non-epileptic and is on anti-epileptic drug. So Renu says it is tramadol. How many agree with Renu? Step 2 analgesic. Preeti, can you be a bit more specific? Tramadol with adjuvant analgesic. Okay, thank you. Thank you all for the responses. Yes, as you have said, it is the patient is having a moderate pain. So the pain, severity of the pain seems to be 5/10, which means that the patient is having moderate pain. The ideal would be step 2 of the analgesic ladder. But tramadol as well as tapentadol are drugs which are prone to produce, which reduces the seizure threshold and has to be used cautiously in patients who are prone to seizures or who are already on anti-epileptic drugs. So, yes, Jennifer. So, as it would be preferable or it is more advisable to start this patient on a low dose of morphine. Though the patient is indicated for step 2 opioids, we'll go with the low dose of morphine in this situation because as tramadol as well as tapentadol can reduce the seizure threshold and the patient can develop seizures. So I just wanted to remind you of this, that though the patient, depending upon the severity of the pain, the patient seems to be suitable candidate for step 2 analgesics, but in this patient, it is preferable to go with a low dose of maybe 5 milligram of oral morphine 4-hourly and assess on the pain, response to pain as well as the toxic signs. So now, what are opioids? Opioids, it's a general term which includes, it can be naturally occurring semi-synthetic and synthetic drugs. They produce their effect by combining with the opioid receptors and their actions are antagonized by naloxone. So opioids can be naturally occurring synthetic or semi-synthetic. And they produce, how do they produce their effect? By combining with the opioid receptors. And these actions, their actions are usually specifically antagonized by naloxone. Such drugs are called opioids. And what are the opioid receptors? Opioid receptors include mu, kappa, delta. Sigma is not a true opioid receptor because its action mediated through it are not reversed by naloxone. So a drug to be opioid, it should act by combining with the opioid receptors and its actions should be reversed by naloxone. But sigma is not considered as a true opioid receptor because the actions mediated by it are not reversed by naloxone. And based on the receptor interaction, the opioids can be classified as agonist, antagonist, and agonist, antagonist. What is an agonist? An agonist means it is so morphine is a mu agonist. What does that mean? This drug combines with the receptor site and produce its effect. For example, morphine is a mu agonist. Morphine combines with the mu receptor site and produces its actions. What is an antagonist? An antagonist is it blocks the receptor activation by the agonist by binding to the receptor site. So, for example, naloxone is an antagonist to morphine. It's a morphine antagonist. What does that mean? Naloxone, when given, it replaces the morphine from the receptor site and binds to the receptor site, thus blocking the actions caused by morphine. So an antagonist drug as such does not produce any effect, but it reverses or blocks the action of the agonist drug. So morphine is a mu agonist drug and naloxone is an antagonistic drug, morphine antagonist drug. And we have another classification called agonist antagonist. So these are drugs which are agonist on certain receptors, but they are antagonistic action on other receptors. So these are the classification of drugs based on their receptor interaction. So moving on to the side effects of morphine. So the adverse effects of morphine can be classified as side effects and toxic effects. Side effects means even with the therapeutic dose, the patient develops these side effects. The most common side effect of morphine, can somebody tell me what is the most common side effect of morphine? The most common side effect of morphine is constipation. 95% of the patients who are on morphine are likely to develop constipation. And then we have nausea and vomiting, then sleepiness, tiredness, itching, dry mouth, urinary hesitancy. These are some of the side effects of morphine. So the most common side effect of morphine is, as I mentioned earlier, it is constipation. So whenever a doctor prescribes morphine, it is your responsibility to ensure that a stimulant laxative is being added along with the morphine. So as long as the patient is on this opioid, on this morphine, the patient needs to be given this stimulant laxative. Otherwise, the patient is likely to develop constipation. So whenever a patient is prescribed on opioids, make sure that a stimulant laxative like bisacodyl is prescribed along with that. The other side effect of morphine is nausea and vomiting. So around 1/3 of the patient develops nausea and vomiting in the first few days. So this is a self-limiting symptom. That means that it goes by itself and is mainly due to the stimulation of the chemoreceptor trigger zone. So the drugs acting on the chemoreceptor trigger zone are usually given along with morphine. Do you remember so those drugs include haloperidol, metoclopramide, and domperidone. So do you remember when we did the intravenous morphine titration, we had given the patient metoclopramide before starting the titration. This is because the patient is likely to develop nausea and vomiting. So when you start morphine for a patient, at least for the first 3 days, start on tab metoclopramide, 10 milligram thrice daily for 3 days. Or it can be haloperidol or domperidone. And antiemetic should be given for the 3 days, because since this is a self-limiting symptom, it will go by itself after this first a few days. So now the other sleepiness and tiredness is another side effect that occurs with morphine, and this is also like nausea and vomiting, it goes by itself. So but when you start a patient on morphine, tell them, when you advise them that they are likely to develop constipation, So they have to take this stimulant laxatives as long as they are on these drugs. Tell them that initial 2-3 days they are likely to develop nausea and vomiting. So either metoclopramide, haloperidol, or domperidone should be taken along with the morphine for the first 3 days. Also tell them that they are likely to develop sleepiness and tiredness, but as days progresses, they'll get over with it. If this continues, then they should inform you. So these are the instructions that you should give to the patient while starting them on opioids. So what are the toxic effects with opioids? So we said the adverse effects that occur with the therapeutic dose are the side effects. Those included constipation, nausea, vomiting, sleepiness, drowsiness. Then we said urinary hesitancy, dry mouth, all this can occur, itching, all this can occur. But if the dose is administered dose is higher than that is required for pain relief, or if the pain is having poor response to the drug, then the patient can develop toxic effects. What are the toxic effects of morphine? The patient can develop delirium, myoclonus, jerky movement, and drowsiness. So we said drowsiness can occur for the first few days, but it doesn't get over. And if the patient is going for extreme drowsiness, continuously the patient is having drowsiness, then that need to be handled separately. So then there are chances of toxicity and we need to address that. We need to either reduce the dose of morphine or look in for whether there are any other signs of toxicities and adjust the dose. So is there any other toxic effect of morphine? Anybody wants to unmute and talk? Is there any other toxic effect of morphine?
Please reply to the faculty, please.
Confusion, respiratory depression,
Vomiting.
Depression.
respiratory depression, pinpoint pupil. Yes. Does opioids produce respiratory depression? So, I have been working in palliative care since 10 years, and in my experience so far, I have not seen any patients on respiratory depression due to oral morphine. And even this article on management of by the Journal of Pain on a systematic review article on the management of opioid side effects in cancer-related and chronic non-cancer pain says the same. When these medications are given as per the principles of analgesic use. Can somebody tell me what are the principles of analgesic use? I had mentioned before the principles of analgesic use.
You people are very attentive, so why can't you respond?
Can somebody tell me what are the principles in analgesic use? We said in the beginning, the medication should always try as much as possible, the medicine should be given.
Hagisri, Priyanka, Sundaravelli.
Yes. Yes, Preeti. Thank you.
By the mouth, by the clock, by the leader, for the individual, attention in details.
Yes. So these are the principles in analgesic use. So I just wanted to remind you on these points because if ever a medication is prescribed orally and the wisely and properly monitored, like monitoring the response to the pain, monitoring for the side effects, then respiratory depression is, and you slowly titrate the dose. then respiratory depression is unusual. Unless there is some other like a condition below that, like if there is a pneumonia or a pulmonary embolism or cardiomyopathy, or the patient is on some benzodiazepines, unless there is some other cause associated with it, alone with the opioids, they are very less likely to produce respiratory depression. But provided the medication is titrated, monitoring the side effects and the response to the medication, response to the pain, and monitoring the toxic effects and titrated slowly, then they are very less likely to produce respiratory depression. Does opioid cause addiction?
Yes, ma'am.
Yes.
Yes.
No. Jennifer says no. So we'll go for a polling. Jennifer says no, but Sundravalli says that yes. Okay. So we'll go with the literature. We'll see what the literature says. So as per the literature, the substance abuse as a result of medical use. So when opioids are used for medical purposes, it is very less low. A substance abuse can occur. That is what the literature says. And always there is a confusion between physical dependence and psychological dependence. And there is overestimation of the risk of addiction. So because we are afraid of addiction, there is situations where the medications are not optimally prescribed when indicated also, because we overestimate the risk of addiction. The patient might develop addiction, and keeping that, because of that, we are fear, maybe that fear, we underprescribe the pain, like opioid medications. So this is what the literature says. And what is addiction or psychological dependence? So as per the American Academy of Pain Medicine and American Pain Society and American Society of Addiction Medicine, addiction is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. There is a compulsive use and continued use, even though, and craving for the medication, even despite the knowing that the use can cause harm, there is a continuous craving to use the medication. That is known as addiction or psychological dependence. And what is physical dependence? It is a state of adaptation that is manifested by a drug class specific withdrawal syndrome. What does this mean? So let me ask you something. How many of you drink tea in the morning? You can respond in the chat box, or
Everyone they are taking tea or coffee.
everyone. Okay.
Amma.
So Sumadhi says everyone is taking tea or coffee. So suppose you don't take tea or coffee, what happens?
They are using some other drink, amla juice, like healthy juices.
Okay. So, okay. Thank you, Sumati, for that. So, Biji says that she develops headache. Priyanka also develops headache. Sorry, Payal develops headache. So suppose Payal and Vijay are staying nearby, and Payal is used to drinking tea. But today she doesn't have tea leaves at her. So they are living nearby flats. And today Payal is not having tea leaves in her kitchen. But she knows that Biji has got some tea leaves in her kitchen, but Biji is not here. So what a Payal does is that she develops headache. She doesn't have tea. So she breaks open into Biji's kitchen and takes the tea leaves from there and makes tea and drinks. What is that? So that is psychological dependence. Yeah, sorry, Payal, for using your name. So that is psychological dependence. So she knows that this is not good. She's desperate. Yes, Jennifer, she's desperate. So despite knowing that this is not the right thing to do, we are not supposed to break open into somebody's home when they are not there. She knows that this is not the right thing, but she's helpless. That is psychological dependence or addiction. At the same time, there were many people who said that they develop headache. If you don't drink tea, they develop headache. That is the withdrawal syndrome. That is physical dependence. So since long, you have been used to providing this to the body. And one fine morning, you say no tea to your body. The body cannot stand it. The body wants tea. So it is responding like some people develop tiredness, some feel very fatigued. So this is the withdrawal syndrome, the way the body responds that we need it. So that is physical dependence. This is just to put it in simple words rather than that big definitions to make things clearer to you. I hope it helped. So next, as I mentioned earlier, we'll have just a comparative cost of opioids so that you have an idea when your doctor prescribes the opioids. You can tell them that without looking into the patient's pocket, if we prescribe such medications, it might not find the expected results because they might not be able to get these medications. So just to see, morphine 5 milligram 4 hourly is costing 3 rupees 50 paise per day. The equipotent dose of tramadol is around 24 to 50 rupees, and that of fentanyl patch is 250 to 400 rupees per day, and that of buprenorphine patch is 1,920, and of methadone is 4 rupees 50 paise. So this will give you just an idea. Whenever you say fentanyl patch, why don't we go for fentanyl patch? Why don't we try buprenorphine patch? Just to give you an idea of the expense part, the cost difference between the various opioids, which can help you to guide your doctors and help your patients. I think with that, I come to the conclusion of my session. Yeah. Open for, can we go with the case presentation first? And then if you have any doubts, you can put in the chat box or we'll take it up after the case presentation. Okay, ma'am.
Can you see my screen?
Yes, ma'am. No.
Can
I don't see.
everybody is able to view my screen that is shared?
No.
No.
Okay, there is a network issue. Please wait for a minute. You can ask the doubts to the faculty. By the time I will clear this.
Okay. If you have any doubts, please feel free to ask.
Yeah,
Sound போடாது. நான் கிளாஸ்ல இருக்கேன்.
Is this? Okay, now are you able to view my screen that is shared? Sumati's case.
Can I start?
Yes,
Can I start, ma'am?
Okay, then go ahead,
uh,
Sumati.
My patient detail. She has age 45, gender is female. Her diagnosis is cancer breast with multiple bone mets. Presented complaints. She has back pain, like catching type. It means sudden muscle spasm. More on coughing, sneezing, bending, etc. Bending time, the root compress will happen. She got 1 month duration. She feel worsening at nights. She has painless lump in the left breast of 6 months. History of illnesses. Her pain of sudden onset while bending when bathing 1 month ago. She got short catching type of pain like a tight bond around the midrib. Pain not relieved by paracetamol. She feel relieved after taking prolonged rest and using pain bomb. The pain attacks increased in frequency over tribal movements. So other than that, she has left breast lump of 6 months. It is painless. She is perimenopausal. She has multiparas. She had breastfed all 3 children. No family history of cancer. Examination. Performance status 1. According ECOG status, she got performance status 1. She is doing all activities, but only symptoms will occur. She is comfortable at rest. She is moderately nourished. She is mild anemia. She has no neck nodes. The abdomen, no organomegaly, no free fluid. In left breast lump of size 4 into 3 centimeters. Her skin and chest wall is free, and her both axillae and other breast is normal, and tenderness over the thoracic spines 5 and 6. And next, treatment and significant investigation. So diagnosis, left breast cancer with bone mets, true cut biopsy of left breast lump. That result is invasive ductal cancer. Hormone receptor positive, that is her hormone epileptic receptor is negative. CT scan of chest and abdomen, no visceral mets or seams. So MRI spine showed multiple bone mets with impending cord compression at disc 5 and 6. So treatment fully bed rest, started on tableted dexamethasone 8 mg TDS. Radiation oncologist opinion obtained for emergency RT2 spine. Tablet paracetamol and ibuprofen TDS and tablet carbapenem 100 mg DD. And medication, psychosocial aspects. Her pain is relieved. Her feeling is she is a housewife whose support to the family is very important. She has a girl going to college whose marriage is soon to happen. She has two other children who are yet to settle. She has middle class family solely dependent on her salary. And medication, her pain is relieved by Brufen 400 milligram TDS, paracetamol 500 milligram TDS, ranitidine 150 milligram BD, tablet dexamethasone 8 milligram TDS, and tablet carbapentine 100 milligram BD. Local pain relief balm like Volini. No other previous medications. And summary. She is 40 years old mother of 3 children. She diagnosed with breast cancer with bone meds, stage 4. She has bony pain, no other visceral meds. Invasive ductal carcinoma with estrogen and progesterone receptors positive. Hormone epileptoreceptor 2 is negative. Negative disease. So she planned for emergency RT2 spine and started on steroids to prevent cord compression. Palliative chemotherapy to be started after that. So main concern. So what is the prognosis? Whether she will long enough to carry out her duties, whether her girl will get it, whether she will have hair loss and removal of breast. So discussion points. So total pain to be addressed. So physical pain to be relieved best way, and psychosocial issues like her concern for daughter's wedding, and spiritual concerns, psychological impact like the future of her own marital life, appearance, etc. Thank you.
Thank you. Thank you, Sumati, for that case presentation. So now,
Thank
Sumati has put forward a few issues of her patients, which she would like to get your opinion about. So it's open for discussion to the participants. So the first point is total pain to be addressed.
Yes,
Any comments from the team?
You have to discuss.
So what do you mean by
So
total pain? Yeah.
Total pain means physical and psychological and social and spiritual. We have to focus to all. This is the total pain.
Yeah. So physical pain relief, which is the best way for physical pain relief. Any comments from the participants other than Sumati? I'd like to hear from others. Let's go back to the pain. Medications, pain again. Pain. Previous slide. Previous. So what are her presenting issues?
Back pain.
Back pain, it's catching type.
It's a catching type of back pain. So do you think something is missing there? Participants, please respond. I've been talking since long. I would like to hear from you all. Jennifer says use of opioids can be started with step 3 opioids. Step 3 analgesics, as she's having bone meds. Neuropathic medications. So we have a lot of suggestions coming in. So having studied regarding the pain and the management, something which I find missing here is the severity of the pain. So that is very important when you deal with a patient. It is very important to record the severity of the pain. Unless you record the severity of the pain, you cannot assess on the improvement or whether the patient is not responding. So to assess that, you need to mention the severity of the pain. So we are not sure about the severity of the pain. Sumati, would you help us in that? Like she is already on NSAIDs, that is step 1. She's not started with step 2.
Yes, ma'am. So she is in 4th stage of bone met, ma'am.
Yeah. But what about her pain? Is she
Pain is
having-
worsening at night only. She's getting
Maybe
severe
severe pain.
pain.
So we need to be
Worsening
more
at
clear.
nights.
Like, yeah. So we need to be more clear about the PQRST of pain.
Yes, ma'am. Yes, ma'am.
So the severity of the pain and how the patient is responding to
She is
this.
complaining. She is complaining only back pain and catching pain only. She is complaining and came to the hospital.
Yeah, catching pain on
After
the.
that, he knows for the CA breast.
Yeah. And how was her pain relief now after the palliative chemo?
So they are taking on the emergency radiation and medical chemotherapies.
Yeah.
They are planning to do for radiation and chemotherapy.
Yeah. So, okay. So her
That
curative.
painkiller they are giving only paracetamol like this. They are giving, but the radiation only. They are
Yeah. So
focusing.
is she having adequate pain relief with that?
So she is using paracetamol and steroids other than the local relief balm and Olini like this.
No, ma'am.
No.
But here that a hospital setup, but other than I don't.
So, participants, I understand that the patient is not having adequate pain relief. How do we go about this patient? The patient is already on brufen and paracetamol. Paracetamol 500 milligram thrice daily and brufen 400 milligram thrice daily. So, what do you suggest? We need to be more clear about the pain, severity of the pain, and how much the patient is responding to these medications. We need to know. If you still say that the patient is having severe pain, even with this NSAIDs, it is, I would say, no doubt we need to escalate to step 2 and see the response to the medication. So if it is a nociceptive pain, the patient, yes, syrup morphine, or I would suggest to see if the patient has adequate pain relief with step 2. Tramadol could be an option. So you can try with tramadol, and with the tramadol, even with tramadol, if you don't have adequate pain relief, Sumati, I would suggest the patient to be started with morphine.
Okay.
And what are the precautions that we should take when we start a patient on morphine?
You have to give
Participants,
antiemetics.
yes, antiemetics. So what would be the antiemetic?
Metoclopramide.
Metoclopramide. How many days are we planning to provide?
Only 1 day. Initial day we have to give.
Yeah, maybe for 3 days. 3 days would be a good choice. For the few days, first few days, yes. And a stimulant laxative. It could be bisacodyl, it could be sodium picosulfate, could be the option. And as long as the patient is on opioid, we need to continue with the laxatives. And the antiemetic should be for the first 3 days. So I think the pain medications should need to be reviewed, and depending upon the response to the pain, you can escalate to step 2 or step 3. Yes. Any comments from the participants? Anything you want to add? So, of course, the total pain has to be addressed. We have to take into consideration the physical, psychosocial, and spiritual aspects, and need to understand what the patient is go through with detailed communication. So, I'm not going into all that since our session is mainly on pain management, and we are limiting that to that. So, in your coming sessions, you will be handling each one of this regarding the psychosocial and the spiritual, of course. So, for the physical pain management in this patient, it would be ideal to see the response to the medications and titer as per the WHO analgesic ladder. You can escalate the medications to step 2 first and then to step 3. If the response is not satisfactory, you can go to step 3.
Step 3.
Okay.
Yes. Yes.
Thank you.
I hope that clears.
Thank you, ma'am.
Yeah.
Yes, ma'am. Thank you very much, ma'am.
Yes.
If anyone has anything to say about the case, okay.
No, ma'am.
Anybody
No, ma'am,
else?
thank you.
Sarla, can you please unmute and ask question? I don't. I see something in the chat, but Sarla, can you please unmute and talk?
Sarala, we
Madam,
not able to understand your
15 years
question.
in my ward, there is
Yeah.
a patient, Rasika, 15 years old. She
Okay.
having a morphine, first 10 milligram for 15 days, then decrease the dose, 5 milligram 4 hourly.
Okay.
Then how to reduce the dose of same patient?
So the patient is currently on morphine, 5 milligram 4 hourly.
4 hourly.
And you want to wean the patient from morphine? Is that what you're thinking about?
And
So you want the
how to reduce the dose of patient?
no. Why you want to reduce the dose of? I
One
just
1 month is already completed with morphine.
so
Kamante?
so Sarla, it's not mandatory that if the patient has completed 1 month, you need to reduce the morphine. Is the patient still having pain? The only so what? Thank you for bringing that up. What is the maximum dose of tramadol that can be given to a patient? What is the maximum dose of tramadol that can be given to a patient? The question is open to all, not only to Sarla. Anybody?
Ma'am, currently she is on paracetamol, 500 mg 6 hourly, and tablet morphine 5 mg 4 hourly.
Yes.
Patient is not having severe pain. She is comfortable with the given doses, but
Okay.
doctors want to reduce her doses and shift her to the one particular dose. Then can we reduce the dose of paracetamol or morphine, or
So-
either give both the analgesics together?
Yeah. So the patient, since the patient is the patient having any toxic signs with morphine currently?
No, ma'am. No, ma'am.
No, ma'am. No. Also with morphine, the patient is having adequate pain relief.
Yes.
Yeah, ma'am. Both they are giving together. That is paracetamol and morphine. She is comfortable with that both the doses and both the
Why you
analgesics.
want to bring the dose down?
How many days we can give the morphine?
There is the only indication is as long as the patient is there with pain, you can continue this medications. Only monitor the toxicity. If suppose the patient is developing myoclonus, jerky movements, delirium, then only you need to reduce the
Reduce.
dose. If
Okay.
not, continue the medications as such. You can reduce the dose of morphine if needed, if indicated. Indicated means that the patient has not some toxic signs, so you don't want to continue with the morphine. If suppose such a situation is there, you can reduce the morphine or you can switch on to some other opioid.
Okay, ma'am.
So
Thank you.
I just wanted to bring in one more point. Yes, tramadol, the maximum dose of tramadol is 400 milligram per day. What is the maximum dose of morphine that can be given to a patient?
More.
5 milligram.
Maximum dose 5 milligram.
Then
So there is no ceiling effect for morphine. You can increase the dose as much as you want. There is nothing like a maximum dose for morphine. The only thing is that we need to monitor the toxicities. So the maximum dose would be depending upon the patient's response to pain and the development of toxicities. If the patient is developing any toxic signs, then you need to reduce the dose. Otherwise, there is nothing like the maximum dose for morphine. But you keep on increasing the dose of morphine, the pain relief improves. If it is an opioid responding pain. If not, the patient develops toxicities, means you need to reduce the dose. So the only indication would be monitoring the toxicities and then reduce the dose of morphine. I hope it's clear to you. Preeti, you want to ask something?
Yes, ma'am. We have another patient that is acute necrotizing pancreatitis.
Okay.
In 2 weeks, he is having moderate pain, which is continuous in range, and he is also having abdominal fullness.
Okay.
How can you please say, ma'am, how to manage this patient, with which analgesics or adjuvant analgesics, or we can keep in on morphine?
So can you write this patient story and send to us, Preeti? Because I need to know more about this patient so that I can give you a reply.
Okay, ma'am. Okay.
Can you just make a small note of this patient, like what is the current status of the patient and what is he on? And please
Okay,
do
ma'am.
mention the pain status of the patient right now, mentioning the severity of the pain and the medications on which he is on.
Okay, ma'am. I'll send the thing.
Yeah, please send it to.
Okay, ma'am. Thank you.
We'll get back to you.
Okay, first of all, I would like to thank Ms. Amrita ma'am for the wonderful session. I think all of you are well aware of the topic now, and you participants were so interactive. Though on some certain times you turned mute, but on because we are very comfortable with you. Let me tell you that. Anyway, I thank all of you for your wonderful interaction and attentive participation. Okay, thank you. I will see you on the next session. Till then, bye.
Thank you. Bye-bye.